Good morning. This is Babak, Larian, here doing another session of Facebook Live on Parotid issues. Today I'm going to actually focus on something really important. The most common and actually really interesting and different type of benign tumor that happens in the parotid gland. And all salivary glands is called pleomorphic adenoma. So let me start by doing the presentation. I'm going to flip the camera around and go through the presentation with you. All right, here we go. So, pleomorphic adenoma. As luck would have it, most of the tumors in the parotid gland are benign. So 80% are benign and only 20% are cancerous, right? And majority of the tumors in the salivary glands, 80% of them happen in the parotid gland. So most of the tumors are there, and most of those tumors are benign. When tumors occur in the other salivary glands, submandibular or the minor glands, the chance of them being cancers is significantly higher, but fortunately the incidence is a lot less. So the World Health Organization has categorized the types of tumors that can occur. There's 15 different kinds of benign tumors, pleomorphic adenoma being the most common. You can see 72% of all salivary gland tumors are pleomorphic adenoma. There's 20 cancers that are of salivary origin, right? Many different kinds, variety of incidences. But when you look overall in terms of pleomorphic adenoma in the parotid gland, 70% of the tumors in the parotid gland, 68% are pleomorphic adenomas, which is a high number. And so it really does require us to really look at this in detail to pay more attention to pleomorphic adenomas. So the focus of this talk, again, is on pleomorphic adenoma being the most common type of tumor, and in fact being fortunately benign. So tumors develop in the salivary glands because salivary glands have multiple parts. The parts that make saliva, the ducts that lead the saliva to come out, muscles that squeeze the gland. So each different cell type can make a different kind of tumor. Now, for years, people have been trying to engineer salivary glands for people whose salivary gland function is not working, and that research has given us a lot of information. We know that there are stem cells, the purplish colored ones, and progenitor cells that turn into the other cells. So these stem cells can become any kind of cell in there. So if a tumor originates from a stem cell, it has the potential of being any type. And so pleomorphic adenomas are tumors coming from the same progenitor or stem cells that has the potential of becoming the gland cell, the duct cell, the muscle cell, or anything around there. And that's what pleomorphic adenomas have. When you look at under the microscope, a normal salivary gland has all these glandular cells, right? Some that produce mucus, some that produce very watery fluid, and then there's ducts here. So magnify that, the normal salivary gland. These are the mucus producing, right? These are the mucus producing cells. These are bubbly looking cells. These are serous, fluidy producing cells. These are the ducts. So the cells produce this stuff, it goes into a duct, and then it comes out. You can see in between these cells there are other structural cells outside of them, right? Those are called mesenchymal cells. Mesenchymal cells are structural cells. This is a pleomorphic adenoma. You can see a disarray and disorganization, whereas here you have organization, here you don't. You can see these clumps of cells, which look like the serous cells, and then you can see other types of cells in between. You can see stretched out cells here, and then in the middle, very little in terms of cells. The cells have the purple, dark purple colored dots in them. That's the center of the cell, or the nucleus. So in a pleomorphic adenoma, you have clumps of cells, and in between you have these areas where there's very little cell and mostly proteinaceous material, sometimes even collagen. So this is collagen. Sometimes they can even make bone, basic bone structure. So that's why it's called pleomorphic or mixed tumor. It's a mix of multiple different types, which makes it very interesting because usually tumors are very uniform. But this particular tumor is a mix of multiple different cell types and multiple different material, proteins and stuff. So pleomorphic adenoma can be myxoid. This is a myxoid tumor, which has a lot of this area, the pink area that doesn't have a lot of cells in it. There can be cellular, where they look mostly like this part, or this part that have cells, or classic. Classic is 50% pink and 50% cellular, right? And those different characteristics allow this tumor to have different properties. All right, so salivary glands, all of them have a capsule. So if you look, the gland itself will have a capsule. These are each different salivary glands. There's a covering on the gland itself, all right? And in the submandibular gland here, when a tumor develops, it develops in the gland that's within the capsule. In the minor salivary glands here, the same thing. But the parotid gland is different because the parotid gland has the facial nerve coming inside of it, dividing into two branches, which go on to, let me actually clear everything up. So the facial nerve comes in, divides into two branches, lower branch, upper branch. The upper branch goes to all the muscles above the lip and further up. Brandon has a question. I'll get to your question, Brandon, at the end of the presentation. Let me finish this and I'll get to you. I will not forget you. So the capsule of the pleomorphic adenoma is also very interesting. The tumor. Now I was talking about the capsule of the parotid gland. This is the capsule of the actual tumor. So the capsule is this thick covering. So all of our organs in our body have thick coverings called the capsule or fascia. The parotid gland, the salivary glands, our intestines, the heart, lungs, everything has a covering. The thyroid gland, nerves, everything has a covering. This covering allows this tissue to glide against each other rather than be stuck to each other, okay? And so the pleomorphic adenomas are interesting, and PA stands for pleomorphic, because the capsule is not consistent. There are parts of the capsule that are thick, like here. There are parts that are thinner, like this part, and there's parts that the capsule is missing, and a portion of the tumor is bulging out. There are parts where the tumor is invading and going through its capsule. The parts where this invasion is completed and there's a capsule formed. These are called pseudopods, right, or legs. And there are parts that are separated and away from it, right? And so this characteristic makes this tumor very interesting and very special. Most benign tumors have a capsule, have this, that's continuous and has no interruption, while pleomorphic adenoma has these interruptions, right? Overall, it's been estimated that pleomorphic adenomas, 35% of them have a breach like this. And the breach usually covers around, on average, 5-6% of the surface, right? Now, the type of pleomorphic adenoma you have, meaning the type that is cellular versus myxoid. Myxoid is the part that has more protein in it rather than cells. The cellular type usually have 4% of its cover opened and breached. The myxoid type that has a lot of protein in it actually can have up to 30% of its cover have gaps in it, holes like this area. So these breaches, right? Incomplete capsules. And so that's meaningful and significant, right? Now let's move on to the next page. So those pseudopods we were talking about, this is an exaggeration of it, but those pseudopods are meaningful in the sense that they are sticking out, and when you do surgery and you remove it, if you get too close to the capsule, you can amputate these pseudopods, and each of those amputated parts can turn into a tumor. So when someone has a recurrence, it's usually either these happening, or if that person had breaches in the capsule and portions of the product or the salivary tumor was pooching out, that could spill. And usually what that happens is that if you're in trying to remove the tumor, if this portion of the tumor is next to a nerve, right? Let's say this is a whole nerve sitting right next to it, right? And if you try to remove the tumor, I'll draw the removal in blue, right? You usually try to get a large margin from here, so you miss those legs. But when you get close to the nerve, you're not going to cut the facial nerve. You're going to get right on the nerve, and that gets you close. And that can be an area where you can have some cells left behind, or an area where when you're pushing here to separate these from each other, this area can spill, right? And that can happen. And that's important, because that happens. Now, there's a Dr. Witt, a very smart doctor, who did research on this, and he found that close to 100% of the pleomorphic adenomas that had been removed in the hospital he was doing the research at and looking at many different things had an area where the capsule was next to the cutting edge, or part of the capsule was taken. And what that means is that even when you get close, even when the tumor is sitting on top of the nerve and you have to get close, the chance of you getting a recurrence is low. So what you have to do is you have to minimize the areas where you're close to the tumor. When the nerve doesn't allow you to be away, you get close, and when there is areas where you can be away, you can't. So if you think in 100% of the cases, they found that the tumor was close to the edge of what you cut, but only 4% had a recurrence. That tells you what you need is someone who's skilled, a surgeon who's skilled, who minimizes that closeness. The less closeness that you have, the less likely it is for the recurrence to happen, okay? And that's the key in picking a good experienced surgeon in doing it. Now these tumors can grow to be any size. Pleomorphic adenomas can be on the smaller side here, bigger side, or massive. This gentleman actually had bilateral, and we did a surgery for him first to take this side out, and a year later he came back to get this one out. And you can see full facial function and symmetry for him. Okay, so even with massive tumors, you can do surgery that can be relatively safe. Now, how do you diagnose when someone comes in with a mass? How do you diagnose it? Well, you obviously have to do a needle biopsy, and there's lots of controversy there. You'll find lots of doctors, lots of ear, nose, and throat doctors that say you have a mass. There's no need to do a needle biopsy. We have to do surgery anyways, and that may be true. Although I don't entirely agree with that, but I think when you go into an operating room, you need to have as much information as possible so you can make the right decision as a surgeon. As a patient, you need to have all the information so you can guide your surgeons as to what you need to do. By that I mean, if the tumor is sitting or wrapping around the nerve and you know that it's benign, in advance you're going to say, I'm willing to risk the tumor coming back, but I don't want to sacrifice my nerve. I'm okay with that, right? That's the patient's decision, not the surgeon's decisions, right? If the tumor is cancerous and you know that it's wrapped around the nerve, then you can bring a reconstructive doctor in there to reconstruct the nerve for you and reconstruct facial movement for you. So having more information allows you better outcome. So I think that's extremely important. Now, a lot of people quote data that, well, there's a false negative rate and it's not accurate. Well, in large studies that looked at it, the accuracy rate of the needle biopsy is 95%. So that's very accurate. And I think, but you know, there's this percentage of people who, when you do a needle biopsy, you just don't get enough material to see what it is. And so it can be non-diagnostic. I'd rather have 75, 80% of patients giving me information that helps guide the surgery, and 25% being about, okay, well, we didn't get the information we wanted, let's proceed, maybe do a biopsy during the surgery. That way you can give a bigger piece and look at it under the microscope at the time of surgery. The false negative rate is also recorded by some people saying, hey, you can get false negative, but that's only 4%. False negative meaning the biopsy says that you have something benign, and on final pathology you find that that's actually a cancer. Now that does occur 4% of the time, but I find when it does occur, usually the difference is between a benign tumor like a pleomorphic adenoma and a cancer that is low grade. The high grade cancers are more obvious on needle biopsies. The lower grade cancers are not quite so obvious, you know. So that's very important. Moving on. And then core biopsy, which is a larger needle when you think the person may have a lymphoma. It's a consideration if you think you can get to it without disturbing the nerve, and that you can see based on imaging. There's a Milan needle biopsy reporting system that helps improve the accuracy and guides you as to what to do. Right? It gives you recommendations as to what to do. Right? All right. So the tumors, ignore these two scans. These are MRIs. On MRIs, on the T2 rated images of MRI, you can see pleomorphic adenomas and parotid tumors lighting up. You can be superficial. Now, let me show you. This is the parotid gland on the site that doesn't have a tumor. Again, parotid gland on the site that doesn't have a tumor. These are cross sections. These are cross sections like this, right? So you're going to see the nose, you're going to see the earlobe, you're going to see the upper teeth at times. Well, you're not going to see the toes, but the upper teeth. And here we go. These are the sockets of the upper teeth, tongue, earlobe, parotid gland. This is the parotid gland on the side that has a tumor. And this is the tumor. You don't see that on this side. This is the tumor. Right? Very obvious. You don't have them on the opposite side. Now, the one thing that I want to emphasize here, this one is a superficial tumor. Right? There is no parotid tissue superficial to it. There's only parotid tissue deep to it. So this is superficial tumor. This one is a deep tumor. There is no parotid tissue here. There's parotid tissue superficial tumor. This one is going from the area that's superficial to deep. So pretty extensive tumor. This one is what we call a deep space tumor, or a deep lobe, parapharyngeal space tumor. The tumor is there. And this is a frontal view. You're looking at the person's front. This is the head, the neck, and shoulder. Head, neck, and shoulder. And you can see the tumor here. This view is good because it can tell you the distance of the tumor, distance between the tumor and the skull. And that bit of information is important because the nerve comes out of the skull somewhere around here to get into the parotid gland. So if you have a distance, right, if you have this gap, you have an area where you can go find the tumor, the nerve first, and protect the facial nerve. Moving on. So the tumors can occur. Here, let's do the tumor in red. The tumors can occur superficial to the nerves, deep to the nerves, or wrapping around the nerves. Now, pleomorphic adenomas rarely wrap around the nerve. It has to be a much larger tumor and it has to be there for a long, long time before that occurs. And sometimes when you have recurrences, you can have multiple different ones, and they can be superficial, deep, or any relationship. So, one of the oddest things about pleomorphic adenomas is the fact that they can transform into a cancer. So again, looking at this pleomorphic adenoma with the cellular areas, the myxoid areas, and so on, these tumors have a chance of becoming cancers. When they become cancers, it's called malignant transformation, and they transform into what's called carcinoma x pleomorphic adenoma. So it used to be a benign tumor, pleomorphic adenoma, and then it becomes carcinoma. This happens more commonly in men over the age of 40 that have had this, and the chances at 5 years is 2%, 2.5%. At 15 years is 10%, and that progression continues. So the longer it's present, the more likely it is to be transforming. The younger the person is that has this, the more likely it is to allow that transformation because there's more time. This is an aggressive tumor. The 5-year survival is less than 40% in all comers, but there's different versions of it. And when it does happen, more than 25% of patients will have tumor spreading to the lymph nodes and potentially to other parts. Okay, so let me address some of the questions that have come as we have been speaking. So Brandon was asking, what is the most dangerous type of cancer to form in the parotid gland? There's a few. Let me go back to that list. Here, let me spin you around. So I don't know if I can tell you the most dangerous, but this acinic cell here and the oncocytic cell tumors, myoepithelial tumors, and low-grade mucoepidermoid are the least aggressive type of tumors in the salivary gland. Adenoid cystic, or least aggressive type of cancer in the salivary gland. Adenoid cystic is probably the most intriguing of the cancers because although it's slow growing, it has a propensity to attach to the nerve and use the nerve as highways to travel. And it's hard to cure because it does like to be persistent and be in multiple areas because it uses the nerve. Once it gets on the nerve, it can go into multiple directions and multiple areas and have skip lesions. So you don't know where the beginning and ending can be. The more aggressive cancers can be the adenocarcinomas, the squamous cell carcinoma, the malignant X pleomorphic adenomas, this one, the high-grade mucoepidermoids. Those can be very aggressive. The carcinosarcomas, the salivary ductal carcinomas can be very aggressive. So those are some of the ones that are more aggressive, Brandon. So Anne Hagstrom. Thank you, Dr. Larian. It's my pleasure, Anne. I'm a 36-year-old Swede living in Spain. I just found out that I have a benign tumor, pleomorphic adenoma. So the perfect conversation for you. 20 millimeter in diameter, which is relatively small. According to the MRI, it's occupying both the superficial part of the gland and the deep part. Okay. Visually, it's situated behind the earlobe. It's uncomfortable since the tumor is pressing upward against the ear and down on the jaw. I have 4 questions. 1, is it possible to see exactly where the tumor is situated in relation to the facial nerve and the greater auricular nerve as other important nerves, veins, blood vessels through an MRI? Not really, because you can't see the nerve. Let me show you what I mean. You can make an estimation. Let me actually. Okay. You can make an estimation, Anne. So, when you have a tumor like this, that has all of the parotid deep to it, then most likely the nerve is coming into this area before going out to the face, right? On the other hand, when you have a tumor like this, where there's no parotid here deep to it, but the parotid is all superficial, then more than likely the nerve is coming and going superficial. Those are guesstimations you can make because you can never see the nerve on an MRI. It's just not this thing. On a CT scan, you can see the hole in the skull where the nerve is coming out of, right? So you can estimate the beginnings of the nerve, but you can't really estimate that relationship truly. Now, having said this, I have seen tumors that look like this and still the nerve was going deep. And I've seen tumors like this, less so here, where the nerve is going superficial, okay? So again, the surgeon's experience is the most important thing in going in there, expecting the potentials, and then addressing it as it comes. Second question, per my understanding, the thicker portion of the actual parotid gland is situated under the ear behind the jaw area. That's actually exactly true. So, and you know what you're talking about. So this is the jawbone, right? And this is the earlobe, right? So the parotid gland is very thin here. Sorry. So the parotid gland is thin here as it goes over the jaw and then becomes thick right between the jaw and the earlobe, just like you said. Since my tumor is occupying both parts of the gland and the trunk of the facial nerve comes out from that area, I believe the greater auricular nerve goes through it as well. Now, the greater auricular nerve is actually very superficial. The greater auricular nerve is always under the skin here. And so I'll show you in another image where the greater auricular nerve is, but does that mean the tumor is sitting on top of the facial nerve, pressing through between the branches down the lobe? What are your experiences with that specific location? So let me tell you. In that, the parotid gland is the thickest and has the most substance in this area. Most of the tumors occur in that area. So this is the area because it has the most amount of real estate. So most of the tumors are occurring. And in pictures that I'm showing you, you can see jawbone, earlobe, here, this is the tumor, jawbone, earlobe, tumor, earlobe, jawbone, tumor. So majority of the tumors happen there. Less tumors happen out here, okay? So that's the most common area. So you have the tumor in the most common area. The good thing about that is that the parotid has the most amount of substance in that area, so the chance of the tumor being there happens more. But more importantly, when you look at the facial nerve usually starts here and then tracks upward, right? So in this location, 1/5 of the parotid gland is deep to the nerve and 4/5 is superficial to the nerve. So majority of tumors, 4/5 of them, happen superficial to this nerve, right? So it is still more likely that you have a tumor that's superficial if you have it in this area, unless you see something like this or something that's all the way deep inside, right? So I would have to look at your images to tell you. But having said that, if you are feeling this tumor between your fingers behind your earlobe, and you can wiggle that around, it's more likely that this is a tumor that's superficial to the nerve than deep. Not 100%, but more likely. Let me get to the question about the greater auricular nerve. So, the greater auricular nerve, this picture that you see here has parotid gland has been removed, right? The superficial aspect of it. So normally there is a parotid gland covering this, right? So when you lift off the skin, all you see is the parotid gland, right? And superficial to this parotid gland is a layer of fascia. We'll draw that. We'll draw it in blue. There's a covering. The parotid gland capsule covers the whole parotid gland, right? And this capsule can be thick, right? And superficial to this capsule is the greater auricular nerve that comes from here and then goes to the earlobe. So if the earlobe is, this nerve comes in this direction. So usually at the beginning of surgery, once I make my incision, I find the greater auricular nerve. I find this nerve, push it out of the way. So I serve the greater auricular nerve on every patient. And then once this nerve is out of the way, so once I dissect it out and push it out of the way like this, it's no longer in my way here, then I can do my surgery and get to the deeper parts. Next question then. When a tumor is situated both above and underneath the facial nerve and it needs to be peeled off or the nerve needs to be removed, is there much high risk of having permanent facial paralysis? Well, if the nerve is removed, then you have permanent facial paralysis. But in primary tumors of the facial nerve, that in all the years that I've been doing this, I have never had to sacrifice a major branch. There's been maybe a few occasions that the tumor was wrapped around a minor branch. And because by minor branch, I mean a branch going to a muscle. Let's cut all this out. So facial nerve doesn't always look like this. Sometimes it has crossover branches. So this branching and this branching may have crossover, which means that some of the nerves, and I'll draw this in green, are coming here, going this one, and then going through here to get to this, as well as this way. So there's two paths of getting to that. So if you have a tumor wrapped around this one and you cut this branch here, you still have nerve going to that. So sometimes that happens, but because during the surgery we have nerve monitors on the different nerve systems, and we have nerve stimulators where we stimulate the nerve and see what movement we get. Because we have that, we can test and see the functionality. If I stimulate here and this area moves, and I stimulate here and this area moves, then I know that there's a double branch going to that area. It's safe to sacrifice. So, but we try not to sacrifice. So in all the years that I've been doing this, I haven't had anyone have permanent facial paralysis, because if we have had to sacrifice, we've done it this way, or if the tumor was massive and big, or somehow the injury occurs, because we are a facial nerve repair center, we repair the nerve and have regaining of functioning, okay? Maximization of functioning. In a 2 centimeter tumor, it's exceedingly unlikely you'll have anything like that. You may have temporary, and that temporary weakness may occur depending on the relationship. If the tumor is far away from the nerve, there's less trauma or bruising of the nerve as you remove it. If it's sitting on it or partially wrapped around it, there can be more bruising of the nerve that can have some temporary weakness. Okay? Going on with your question. Will it be harder to remove the tumor intact and with a sufficient margin? No. Again, if you look at this picture here that we have right there, this tumor is sitting on this branch, right? So I can get a margin, wide margin here, get close, wide margin, get close, wide margin, get close. And so I have a wide margin all around except in those 3 areas where the tumor is sitting on the nerve. So minimizing, again, the skill of your surgeon is here, where they can maximize where they can maximize and they can minimize the margin to protect the nerve. And you don't want anyone to sacrifice a branch of your facial nerve, a very important nerve, for a benign tumor, because the chances of that tumor, as you decrease the number of cells recurring or becoming cancerous, is significantly less. So it's a game of statistics that you're playing in a sense. I'm just reading your question here. If I look dazed. So if the tumor is both superficial and deep. Now, when a tumor is both superficial and deep, that means the tumor, it's not that the tumor is superficial here, wrapping around the nerve and going deep, because the tumor is, okay, so the tumor is one cell that becomes two become four, and then they grow like this. And if the nerve is next to it, they generally grow around it, like this. I'm gonna draw the nerve in green here because it's hard to see. So if the nerve is there and the tumor is growing, the tumor generally does this instead of going around and doing this thing. In the patient that had the massive one, this happened, but that takes years and years of it being present. In a less, oh, sorry, you're looking at my face. Let me redraw all that I'm writing. Okay, sorry. So tumors grow, one cell becomes two cells become four cells, and then this grows and grows and grows. If there is a nerve, we'll draw it in green so it's visible, and the tumor is growing, it generally grows around it. So it's both superficial and deep to the nerve, but it doesn't wrap around it. You don't get this. You only get this when someone has this tumor in place for 20, 30 years and has had the opportunity to grow, and now it's grown in all directions. Generally, what you get is this. So if it's superficial and deep, it's going in between the branches and going deep, okay? Yeah, and the larger the tumor is, there are potentially more breaches in the tumor, more possibility of spillage. All of that happens, and again, that has to do with the skill of your surgeon, the relationship with the nerve, your own nerve anatomy, and all those things. Question four, I'm in the process of finding a skilled, experienced surgeon. It doesn't seem very common in Spain, at least not where I live, or in Sweden. The surgeons perform this kind of operation several times a week. They do one surgery every other month or less. Reconstruction and preventing surfacing aren't very common either. This is making me really anxious and afraid. Are you familiar with competent surgeons in Europe? And unfortunately, I don't know any. I don't know the competency of any surgeons in Europe. It's hard for me to recommend surgeons. Let me turn this around and explain. It's hard for me to recommend surgeons that I haven't seen in the operating room and how they operate and how they function, both in the operating room and in their clinics, both being equally important. Because someone may come and do a presentation that's fabulous, but their skill sets may be lacking, okay? And I wouldn't know that unless I talk to their patients or I saw them in the operating room. So I don't know anyone that I've seen them in the operating room to recommend to you. Unfortunately, I wish I did, because I get asked that question often. But you know, there's lots of patients that travel to known parotid surgeons to have surgery in the U.S. and elsewhere. Anyways, best of luck. Hopefully this helps you. And Sandeep Naidu, in our operation, we operate under a microscope that helps preserve the nerve very well. What's your opinion? Well, I always do this operation with what we call loops, which is surgical loops, which is glasses that have magnifiers on them. That my magnifiers magnify the field to 3.5 times the size of what it would be. It allows me to see the nerve branches more accurately, more precisely, and allows me to do a more precise surgery. So I'm a huge fan. I think this surgery really requires it. Richard Hayes, stage 4C carcinoma pleomorphic adenoma. Richard, there's no question in there, but I'm sorry to hear that you or a loved one has something like that. You know, the type of carcinoma pleomorphic matters. So if the carcinoma pleomorphic is more on the adenocarcinoma side, or more on the salivary ductal side, it tends to be more aggressive. If it's more on the myoepithelial version, it tends to be less aggressive. The other thing that matters is when they take these carcinomas out, they look at it under a microscope. In addition, they do tumor profiling to see what kind of proteins is on the surface. Some of the proteins we have antibodies to. So if there is a HER2 new protein on the surface, we have an antibody towards that, Herceptin, that can activate the immune system to attack those cells. So it really is a more complex question in regards to a carcinoma pleomorphic. There's many different factors. But if you have a stage 4C, if the person has a stage 4C, obviously this is an aggressive tumor. It's been there a little while, and now it needs to be addressed. And surgery is the primary mode, followed by chemotherapy and radiation. And hopefully there are proteins where you can use immune markers for that. All right, and Gallowich, copying from an earlier post. Apologies if this has been answered. My question is related to the SCM flap. What impact does this have on the movement of the neck? Fortunately not, because we are using only portion of the muscle flap. So let me see any images for you. So for the faint at heart, this is not for you. Let me see pictures of the muscle flap here. So this is the SCM muscle right there, right? When you do a cross section of the SCM muscle, it is a relatively thick muscle, right? When we want to do when we've done our parotidectomy and want to cover the parotid gland, right? And this picture shows the nerve that goes to this muscle, which is very deep. It's deep to your jaw. Anyways, we use only a portion of that muscle, right? And we rotate that portion. So when we're talking about this muscle, we are using this much of it. So what you see here being brought over is this portion of the muscle being brought over. So the muscle is mostly intact, and because the muscle is intact, you have no deficit in terms of movement of the neck, functioning. At the beginning you have scarring forming and the inflammation, but in time with stretching exercises, all of that goes away and you have full function. Is any physiotherapy required following this intervention? Yes. I mean, it's not required. What I mean by physiotherapy is actually you doing stretching exercises. So I don't know how, I'd say maybe 1% of my patients get physiotherapy and 99% do stretching exercises at home, and this problem is it's resolved on its own. The additional benefit, not only by doing this, you prevent you prevent a divot on the side of the face, which is cosmetic, but more importantly, you create a barrier between the parotid gland and the skin, and you stop Frey syndrome, which is sweating when you get hungry. The nerves that used to go to the parotid gland that you removed, the portion of the parotid gland that you removed, that instructed it to produce saliva, if you don't put a barrier, it can grow into your skin, and then every time you get hungry or you eat, you would sweat. Because those sweat glands are similar to salivary glands in the way they function and the way they have nerves communicating with them. So that's important. I do a reconstruction, and we do at our center a reconstruction on every single patient, and we use more than one barrier in the great majority of times, just to not only create harmony and symmetry in the face, but also, more importantly, prevent sweating on the side of the face. Okay, and then the next question is there any impact on recurrence rates of pleomorphic adenoma? Doing a reconstruction has no impact on recurrence rate. It's really doing an intricate surgery that has the most impact on recurrence rates. Do you perform this procedure yourself or with Dr. Azizadeh? Dr. Azizadeh is my partner, who's a facial nerve specialist and a reconstructive specialist. On the patients who have deeper, more complicated or recurrent tumors, I will use Dr. Azizadeh. In cancers, I oftentimes use Dr. Azizadeh because we may have to reconstruct the nerve. But in the smaller tumors, I do majority of those on my own. So it really depends on the configuration, size, shape, type of tumor that there is to see if I need my partner's assistance or not. And then there's a question, Brittany Lee Andrew. I had a pleomorphic cross adenoid cystic carcinoma stage 1 when removed. Did 30 rounds of radiation to my part. So adenoid cystic carcinoma, I'm assuming what you mean is that they did a needle biopsy that came back as pleomorphic adenoma and the final was a adenoid cystic carcinoma. So you had a false negative in a sense, I would assume. Do you think that is sufficient? 30 rounds of radiation is appropriate. It really depends on your margin, Brittany. If the surgery came to negative margins, then the radiation is more than adequate. You know, with a negative margin, some would argue you wouldn't even need it. When you have a positive margin, or if the tumor was involving branches of the nerve, then 30 rounds of radiation is exactly appropriate. But you need close monitoring. These can be tenacious tumors, adenoid cystic carcinoma, like I explained it. They're very interesting and very odd. There are lots of people who are living with metastatic adenoid cystic carcinoma. We know that on average, people who have metastatic disease live another 7 years after it has spread to other parts of the body. This is a very slow-moving tumor. It can be tenacious, but it's also slow-growing. So, you know, the first surgery is the most important one when someone does a good surgery, and during the surgery figures out this was not a pleomorphic. It doesn't look like a pleomorphic adenoma. It's not acting like a pleomorphic adenoma, and so on. You know, when you're in there and you see that something looks fishy to you, you take a sample, you send it to the pathologist, let them look at it under a microscope. You act as needed. You do what needs to be done for that, right? During that same surgery. Again, expertise of your surgeon is very vital in giving you the best results. And then you take it out, you do what's needed and appropriate. You assess the lymph nodes in the neck to see if there's any lymph nodes that are enlarged. Usually in the office, I do an ultrasound to make assessments like that anyways, to give me more information. So I think doing an ultrasound by your surgeon is important because it gives you information that could be helpful during your surgery. In any case, and then you do the appropriate thing, you do the reconstruction, and then if it does come back as adenoid cystic carcinoma or something else on the final that was not expected, then you follow that by radiation or immune therapy or whatever is needed, okay? Brittany says they are very slack with monitoring. Brittany, you're a year out. And so adenocystics generally take a few years to show themselves. So I'm not worried yet, but I do think you should do an MRI as a baseline now to see what everything looks like. So you can have it as a comparative source, you know, so that 5 years down the line, when you do an MRI in somewhere else and someone says, I see a lump here, you can compare it to the MRI at 1 year and say, hey, that lump was there and it's exactly the same size. That probably is a scar, not a tumor. So that's really important. I would say, what I do with my adenoid cystic patients, I do every 3 month check of the patient. I feel their neck, I feel the area. I have them do an MRI yearly, depending on the extent, the amount of positive margins and so on they have. And I actually have them do a CT of the chest at least once every 2 years, okay? Because that's the area adenoid cystic carcinoma like to spread to. It's the lungs, and so I would do that as well. And if the positive margin areas for you was a lot, you may consider doing a PET scan at the end of the year or two, just to kind of get an idea. PET scan is a whole body scan that looks for activity, so that may be another consideration, Brittany. Best of luck, my dear. It can be very scary, but also if your tumor was small and your margins were fairly negative or only small area positive with that 30 rounds of radiation, it's very possible that you may have cured yourself already, my dear. So best of luck with that. And then the last, and Brittany says, I had an MRI, but I had to ask for it. Good. There's nothing more important than being your advocate when it comes to healthcare, okay? So what you're doing is right. Getting around, getting more information, seeing these sessions, looking at information on adenoid cystic carcinoma. There's an adenoid cystic carcinoma support group. There's actually, I think, a society, adenoid cystic carcinoma society, that you can look online and get information on, and become a member and get info on that. And I think that would be very much helpful to you in getting you information and finding some support there, and finding people who have experience. There are actually a roster of doctors who deal with adenoid cystic carcinoma, so that can be helpful in finding a person locally where you live that has some experience with it, okay? And then being an advocate, pushing for your MRI every year, right? Getting a chest CT scan a year from it, which is at the end of year 2. Just remember this, every 2 years, you do your CT scan, every year you do an MRI. Don't budge. Don't let them talk you out of it, okay? And if you find a doctor, an ENT that can do an ultrasound for you in the office, even easier. That can be done more frequently without much problem, all right? Best of luck, dear. Terry Morgan, last question. My parotid tumor doubled in size in 5 months and now slowed down. Having biopsy done in October. The waiting is hard. Terry, why wait till October? That's the question I have for you. The fact that it has slowed down growing is encouraging, but you know, if you can get to do the biopsy sooner, you have information and you can take action. But hopefully what you have is a cyst, not even a tumor, so it's just fluid filled, and that's why it doubled up inside, and that's why it slowed down. And if that's the case, you may not need surgery or anything like that, right? And hopefully that's what you have, Terry. But until you put a needle in there, you don't know what you're dealing with, you know? An imaging can help, an MRI can help distinguish between a cyst and a tumor, so that may be something. If you can get that done sooner, get that, at least that gives you some bit of information, but you just need more information, all right? Best of luck, Terry. In any case, it's been wonderful. It really is an amazing platform to be able to talk to people from all around, including Spain and all around the US and other countries, and I'm very happy and lucky to be able to do this. Best of luck to all of you, and I'll see you next month. Bye.